Thanks everyone for joining today. Thanks to Dr. Crawford for inviting me to give this grand rounds. So the title of my talk is an update on treating the chemotherapy-naive metastatic hormone-sensitive prostate cancer. And the second part, we'll talk about the AR-V7 biomarker in castration-resistant prostate cancer. These are my disclosures. So this talk will be split into two parts. The first half is to discuss the new landscape and the new data for patients that have metastatic hormone-sensitive prostate cancer, which is also called hormone-naive or non-castrate prostate cancer. And the interest in this disease state started about 3 or 4 years ago when we heard about the results of this study called the CHARTED study, ECOG 3805. And in this study, patients that had metastatic prostate cancer who had not yet received hormone therapy were randomized to receive either ADT alone, androgen deprivation therapy alone, or androgen deprivation therapy plus 6 cycles of docetaxel chemotherapy. And many people are familiar with this trial. This trial looked at overall survival as its primary endpoint, and as can be shown here on the green curve, the overall survival in patients with metastatic hormone-sensitive prostate cancer was higher with the addition of 6 cycles of docetaxel compared to those patients that received the androgen deprivation therapy alone. And interestingly, the study was then split into these two subgroups, which were prospectively defined. The first subgroup was the high-volume disease, which was defined as 4 or more bone metastases, one of which had to be outside the axial skeleton, or a visceral metastasis. And in these patients with the so-called high-volume disease, there was a very clear and large difference favoring the addition of docetaxel. However, in the low-volume disease, there did not appear to be any additional survival advantage with the docetaxel above and beyond ADT alone. And this has been further confirmed by a second study done in the UK called the Stampede Trial. And in this study, there was a broader population of patients included. This not only involved metastatic patients, but also non-metastatic patients as well. What I'm showing here is the overall survival for patients in the M1 cohort only. And this study was almost identical to the American CHARTED study, in that patients got 6 doses of docetaxel plus androgen deprivation therapy or androgen deprivation therapy alone. And again, there was a survival advantage. What I want to point out here is that because the UK Stampede study included both the M0 patients as shown here and the M1 patients as shown here, they could look at subset analyses to see whether the benefit of docetaxel was primarily in the metastatic or whether it also extended to the non-metastatic patients. And what this forest plot shows is that the survival benefit with docetaxel was primarily restricted to the metastatic hormone-sensitive patients, not the non-metastatic. And an interesting update of the American trial, the CHARTED study, which was presented 1 year ago at the ESMO meeting, with additional follow-up and additional death events, showed that in the high volume subset, again, these are patients that have 4 or more bone metastases, one of which is outside the axial skeleton, or visceral metastases, the survival benefit holds up with the addition of docetaxel in addition to ADT. However, in the low volume group, the curves become superimposed, and the hazard ratio for death is 1.04, suggesting that in patients that have low volume hormone-sensitive disease, there is no clear added value to the docetaxel chemotherapy. That's not published yet, but it's pretty important because there were some people that were arguing that all men with hormone-sensitive metastatic disease should be getting chemotherapy in addition to ADT. And this updated analysis perhaps suggests that the low-volume patients may not be benefiting from the chemotherapy. Now, a couple months ago, we had a new study called the Latitude Trial. And this study was asking the question of whether Abiraterone added to ADT improved survival for men with metastatic hormone-sensitive prostate cancer. In this study, patients were included if they had high-risk metastatic hormone-sensitive disease, which was defined as a Gleason score above 8 and or visceral metastases and or 3 or more bone metastases. And to be included in this trial, patients had to have 2 or more of these so-called high-risk features. And then they were randomized to receive androgen deprivation therapy alone or androgen deprivation therapy plus Abiraterone at the FDA-approved dose plus prednisone 5 milligrams once a day. And in this trial, which was subsequently published in the New England Journal of Medicine, the addition of Abiraterone was beneficial in terms of survival compared to ADT plus placebo, with a hazard ratio of 0.62, so approximately 40% reduction in the risk of death by adding Abiraterone up front. And there was also a big and significant progression-free survival advantage with a roughly 50% reduction in the risk of progression. In the subgroup analysis of the Latitude study, the addition of Abiraterone on top of ADT appeared to improve survival in all the subsets, as you can see here. So this was a very convincing and a very consistent benefit, with the hazard ratios being roughly 0.6 to 0.7 across all of these subgroups. So a very important difference. Now, the Stampede study also had an Abiraterone arm. And again, the Stampede study was different from the Latitude study in the sense that this included both M1 and M0 patients. So the entry criteria for the entire Stampede trial are the same for all the different cohorts. And in the Stampede study, the Abiraterone arm compared to the standard of care arm, it's broken up into the M1 cohort and the M0 cohort. Let's start with the M1 cohort on the left. So here there was a very clear and statistically significant survival improvement of about 40% risk reduction in death with the addition of Abiraterone. However, in the non-metastatic, the so-called M0 population of the Stampede study, there did not appear to be, at least not a statistically significant improvement in survival. So again, the Stampede study, once again suggesting that the addition of Abiraterone would be beneficial for the M1 disease, metastatic hormone sensitive, but not in the non-metastatic hormone sensitive. And the subset analyses from the Abiraterone arm of the Stampede study are also on the left here, showing that the hazard ratio favors the addition of Abiraterone in almost all subsets. One interesting thing to point out is the age. Patients that had an age above 70 years old, at least in the subset analysis, did not really appear to benefit that dramatically from Abiraterone. So perhaps patients with metastatic hormone-sensitive disease who are older than age 70 may not benefit as much as younger patients. But the remaining groups here all strongly favor the addition of Abiraterone. So the Stampede study is a very big trial. It's a multi-arm, multi-phase study. I used to call it the octopus trial because it had 8 arms. Actually, now it's got 12 arms. So I don't know what I need to call that. But one of the interesting things that was presented at the ESMO meeting this past year, 2017, was a direct comparison of the Stampede Abiraterone arm versus the Stampede Docetaxel arm. And the purpose of this was to try to answer the question, in patients that have the option of receiving ADT plus Abiraterone or ADT plus Docetaxel, which one is preferential? And so when you look at this analysis that was presented at ESMO, has not been published yet, if you look at failure-free survival, in which PSA was included in the definition of failure, it appears that the standard of care plus Abiraterone does better than standard of care plus Docetaxel. However, as a word of caution, when you look at the overall survival, which was the primary outcome of the Stampede study, you really see superimposed Kaplan-Meier curves that do not necessarily suggest that ADT plus Abiraterone is superior to ADT plus Docetaxel. So I think these data can be misinterpreted by some people as suggesting that abiraterone might be preferential over docetaxel, but truly, when you look at overall survival, the two therapies appear to be extremely equivalent to each other. So one question that arises is, how do you choose between ADT plus abiraterone or ADT plus docetaxel if the patient has both options? And one way to choose is to look at the toxicity. So on this table here, I've highlighted the toxicity of ADT plus docetaxel versus ADT plus abiraterone plus prednisone. And what you can see here circled in red is that patients that receive ADT plus docetaxel have a higher rate of neutropenia, including febrile neutropenia, compared to patients with abiraterone that almost never receive or experience neutropenia. And on the other hand, the abiraterone causes more cardiovascular disorders. This is primarily a result of hypervolemia, which results in fluid overload, hypertension, and hypervolemia. In addition to a risk of hepatic disorder, which is characterized by elevations in the transaminase levels of the AST and the ALT. So ADT plus docetaxel, more neutropenia, ADT plus abiraterone, more cardiovascular disorders and more hepatic disorders. And this slide shows a recent review article that was published by Dr. Armstrong, myself, Dr. Sweeney, and Dr. McNamara, where we attempted to summarize all the data comparing ADT plus docetaxel versus ADT plus abiraterone. And we have this table in the paper, which I think is quite helpful to make some recommendations about which patients may favor ADT plus docetaxel and which patients may favor ADT plus abiraterone. So patients choosing docetaxel might be those who prefer to have a finite course of therapy. In other words, 6 cycles of docetaxel lasting 18 weeks, and then they're done. Or patients that have problem with swallowing or absorption of oral medications, or patients with poor diabetic control in whom the addition of prednisone in conjunction with abiraterone might make their diabetes worse, or patients that have heart failure, hypervolemia, or liver dysfunction. Those patients may wish to avoid abiraterone. And for the majority of the rest, abiraterone would probably be the preferred approach, especially for those that are unfit for chemotherapy, or those that prefer an oral over an IV therapy, or those that have pre-existing peripheral neuropathy, or patients that prefer to have fewer clinic visits, which are typically required with an oral therapy as opposed to an IV therapy. So I will now shift to discuss the second part of the talk, which is the AR-V7, a biomarker in the context now of metastatic castration-resistant disease. So we're shifting from the hormone-sensitive space to the castration-resistant space. And so what is the AR-V7? It's a splicing variant of the androgen receptor, which results in a truncated protein that lacks the ligand binding domain of the AR molecule. So this is the three-dimensional crystal structure of the AR full-length protein. This is the normal AR. And as you can see here on the right side, this LBD stands for the ligand binding domain. And this is the pocket up here. And this is where the ligand, in other words, dihydrotestosterone, binds. And then AR-V7 crystal structure is shown here on the right. And as you can see, it's missing this whole piece, which is called the LBD, ligand binding domain. And so therefore, this form of the androgen receptor is unable to bind the ligand, but it's constitutively active, which means that it can activate transcription in the absence of the ligand. But more importantly, this version of the androgen receptor should not be affected by abiraterone or enzalutamide because it's missing the ligand binding domain. So the hypothesis is that patients that have this abnormal version of the androgen receptor in their tumors would not be responsive to the novel hormone therapies such as enzalutamide and abiraterone. And for those of you that care about molecular genetics, it's not a DNA mutation, it's an RNA mutation, and it results in a abnormality of this intronic area. So the intron is the genetic code between the exons, which is normally not translated into a protein. But if you have an abnormality within this third intron, it results in a truncation of the protein product with a complete deletion of the red domain, which is the ligand binding domain. So I'm going to start with the summary of what we currently think we know about the AR-V7, and then I'm going to work backwards and show some of the data. So we and others believe that AR-V7 can be detected from circulating tumor cells in men with metastatic castration-resistant prostate cancer, and that it is a sign of primary and acquired resistance to both abiraterone and enzalutamide. However, AR-V7 positive patients might still remain sensitive to taxane chemotherapies like docetaxel or cabazitaxel. In AR-V7 positive men, taxanes appear to be more effective than AR-directed therapies, including abiraterone and enzalutamide, whereas in AR-V7 negative patients, taxanes and AR-directed therapies are equivalent, and most people would pick an AR-directed therapy in this setting. And if all those statements are true, which remain to be confirmed, AR-V7 might be a treatment selection biomarker that will help select chemotherapy versus AR-directed therapy for men with CRPC. This was the initial paper, which I consider to be a pilot study, where we looked at 62 patients that were about to receive either enzalutamide or abiraterone, and we checked their blood for circulating tumor cells that contained the AR-V7 splicing variant using an mRNA detection. And the gray bars on this waterfall plot of PSA response represent the patients that had the AR splice variant 7, AR-V7. And as you can see, all patients except for one did not respond, and all the responding patients are the ones in black, which had no evidence of AR-V7. And if you look at progression-free survival or overall survival, the red curve represents patients with AR-V7 positive circulating tumor cells, and the black represents AR-V7 negative patients. So the negative patients do better with ABI and ENZA, both in terms of progression and in terms of overall survival. Now, that was only 62 patients, so we subsequently expanded that trial and recently published in the Journal of Clinical Oncology our expanded experience with 202 consecutive patients. And here what we decided to do was we decided to classify the biomarker into 3 different categories. The first category are patients that were CTC negative. These were men that had a blood test but no circulating tumor cells could be detected. The second category was patients that were CTC positive but AR-V7 negative. So they had detectable circulating tumor cells, but they did not contain AR-V7. And then the third category was patients that had circulating tumor cells and AR-V7 was expressed. And when you look at PSA responses, the most favorable PSA responses were seen in men that didn't have any circulating tumor cells in their blood. Intermediate PSA responses were seen in patients that had circulating tumor cells but no AR-V7. And then the worst PSA responses were in patients that had positive circulating tumor cells that expressed AR-V7. And the bottom Kaplan-Meier curves show PSA progression, radiographic progression, and overall survival for men with CTC negative group here, the blue, CTC positive, AR-V7 negative, which is intermediate in yellow, and CTC positive, AR-V7 positive, which is the worst group. So using these 3 different definitions of the biomarker, we could separate patients that had the best prognosis, which were the CTC negative guys, intermediate prognosis, which were the CTC positive but AR-V7 negative, and then the worst prognosis, which are these guys that have AR-V7 positive circulating tumor cell positive blood samples. This was validated by several other groups, including the Memorial Sloan Kettering group, with Howard Scher being the lead at that site. And not only did this confirm that the presence of AR-V7 decreases the sensitivity of AR-directed therapy, but they also showed, as had we, that these patients do retain sensitivity to taxane chemotherapy. So if you look at this forest plot here and you focus on this bar here, which is the AR-V7 negative patients, you can see that in the AR-V7 negative patients, it doesn't really favor either taxanes or AR therapy. They're both roughly equivalent. However, in the AR-V7 positive patients, which is this bar here, you can see that the hazard ratio favors the left side, which is the taxanes. So this again suggests that in the AR-V7 positive patients, a taxane would give a better response than an AR therapy, but in the AR-V7 negative patients, both an AR therapy and a taxane would be equivalent. So this is a schema that I think can help clinicians to use AR-V7 testing in the clinic. So if a patient develops progression after a GnRH agonist or antagonist, and they develop castration-resistant disease, they could have AR-V7 tested from circulating tumor cells. If the AR-V7 is negative, that patient could receive either abiraterone or enzalutamide, and they would be expected to have a very favorable response. If that patient subsequently progressed on the AR therapy, they could then receive a second AR-V7 sample at the time of progression. If the AR-V7 remains negative, they could switch from one AR inhibitor to another, for example, abiraterone to enzalutamide or vice versa. However, if the patient has converted from a negative to a positive AR-V7 status, then they could be switched at that point to a docetaxel chemotherapy. On the other hand, if the AR-V7 test was positive at the first evidence of castration resistance, that patient should probably not receive ABI or ENZA and should probably receive docetaxel immediately. If the docetaxel eventually fails, that patient could be retested. There are cases where the AR-V7 status converts from positive to negative during the chemotherapy treatment, and those patients could perhaps receive an abiraterone or enzalutamide as a secondary treatment for CRPC. However, if the AR-V7 status remains positive after docetaxel, then they could receive a second taxane chemotherapy, such as cabazitaxel. So how can one test AR-V7? There's two ways. One is to send a blood sample to Johns Hopkins, and we are a reference laboratory for this test. We have a clinical grade version of the test. This is the screenshot from the Epic ordering system. If you don't have Epic, you can also order it through a paper form that can be faxed to us together with the blood sample. The blood sample has to be collected and shipped within 24 hours because the RNA within the circulating tumor cells will degrade if it's longer than 24 hours. And our website has the form available and instructions about how to ship it to Hopkins. And the second option is a commercial test that's about to go live by a company called Epic Sciences, and this is their website. It's actually AR-V7.com. And Epic Sciences has gone live with this test in the state of California. That's why it says limited release. And in the next 2 to 3 months, they will offer testing throughout the entire country. This test is a protein-based AR-V7 detection, so it doesn't have the same problems about the RNA degrading. So the samples do not need to be received within 24 hours, which makes the test a little bit more user-friendly. So two potential options to order AR-V7 testing. My guess is that in the future, the Epic Sciences one will be the more widely used compared to the Hopkins one, which requires RNA and a rapid shipping. And one of the questions that arises is, what is the clinical utility of this test in a real-world situation? So we recently published this study in a new journal called JCO Precision Oncology, where we actually sent questionnaires to 150 physicians who were ordering the Johns Hopkins AR-V7 test. And we asked them a series of questions to determine how the test did or did not influence their clinical practice. The first question we asked is, did the AR-V7 assay result in a change in management for your patient? And as you can see here, if the result of the test was CTC negative or AR-V7 negative, in most patients that did not result in a change in therapy. But in patients that had a CTC positive, AR-V7 positive result, almost 2/3, about 61%, did induce a change in therapy from their oncologist. The second question was, did the patient achieve a PSA 50 response after this test result was released? And Interestingly, in patients whose physicians changed therapy based on the biomarker, 53% of them had a PSA response, whereas patients who did not change therapy depending on the biomarker, who basically did what they would have done anyway without the biomarker, only 30% of those had a PSA response. So this suggests that if you use the AR-V7 test and you actually change your therapy based on the result, your patients are slightly more likely to achieve a PSA response with the next line of therapy. And then the third question tried to answer what was the next line of therapy and how did the therapy change. So I want you to focus on the last line here, which is patients that had CTC positive, AR-V7 positive results. So 43% of those patients would have received an AR therapy, but their doctor changed them to a taxane as a result of having an AR-V7 positive test. And then the other big group, which is another 43%, were people who actually decided to go on a clinical trial as a result of having a positive AR-V7 test. So approximately 86% of people who had a AR-V7 positive test either changed from an AR therapy to a taxane or went on to a clinical trial as a result of that knowledge. So this is a real-world analysis of physicians across the US and Canada ordering the Johns Hopkins AR-V7 test and how it helped them change their management. So this kind of does prove on a very preliminary level the basic clinical utility of this test. So the last few slides are about clinical trials looking at targeting AR-V7, and this was a compound called Abiraterone, and Abiraterone was an oral compound that supposedly degraded the androgen receptor splice variant 7, and there was a study called the ARMOR-3 trial, which was a trial in which patients were screened for AR-V7 using an assay developed by Qiagen, and they were then randomized to receive either Abiraterone or enzalutamide. Unfortunately, this study was terminated early because these patients progressed so quickly that many of them had clinical progression even before they got to their first CT scan and bone scan. So the primary endpoint of this study, which was radiographic progression-free survival, was uninterpretable. So this trial, unfortunately, will not result in Abiraterone being approved for prostate cancer or for AR-V7 prostate cancer in specific. Another strategy, which was achieved by a drug called EPI-506, made by a company called ESSA Pharmaceuticals, was to target the N-terminal domain of the androgen receptor. And the N-terminal domain is present not only in the normal androgen receptor, but also in the androgen receptor splice variants. Unfortunately, this compound was also terminated after the phase 1 study was conducted and did not really show any significant anti-tumor activity. So right now, we have an unmet medical need to develop effective therapeutics for patients that have AR-V7 positive prostate cancer. So this is really an area of active research and investigation. So I'm going to end there, and thank you for your time.